Hello, my name is Kirchgesner from the gastroenterology unit of Saint-Antoine Hospital, Paris. On behalf of all my co-authors, I'm very pleased to present you the results of our study about cardiovascular disease and IBD recently published in Gut. Atherosclerosis is now defined as a chronic inflammatory condition, and chronic systemic inflammation has been associated with an increased risk of acute arterial events in chronic inflammatory disease such as rheumatoid arthritis. However, this risk remains still unclear in IBD, and risk differences between age categories, gender, and the impact of IBD activity may explain controversial findings in the literature. So, the aim of our study was to assess the magnitude and independent drivers of the risk of acute arterial events in patients with IBD. To address this question, we assembled a nationwide cohort of IBD patients based on the French Hospital Discharge database, which covers the entire French population. We included all patients aged 15 years or older identified with IBD. First, patients identified with IBD before 2010 were screened for exclusion criteria between 2008 and 2010 and followed from 2010 to 2013. Patients identified with IBD after 2010 were followed from the first identification of IBD in the database. Study outcome was the first occurring acute arterial event during follow-up, including cerebrovascular disease, ischemic heart disease, and peripheral artery disease. Patients with a history of acute arterial event and chronic cardiac disease were excluded. First, we calculated standardized incidence ratio and re-stratified analysis on age, sex, and number of traditional cardiovascular risk factors. To assess the impact of IBD activity, we also performed a multivariate Cox regression analysis, notably adjusted for all traditional cardiovascular risk factors. An IBD-related hospitalization was used as a surrogate marker for disease activity. During follow-up, for each IBD-related hospitalization, disease activity was defined as a 3-month period before and after an IBD-related hospitalization. Overall, we included more than 210,000 IBD patients, and we identified 5,554 acute arterial events, with the majority of ischemic heart disease. Patients with IBD were at increased risk of acute arterial events compared to the general population, and similar findings were observed in all arterial disease subgroups. Higher risk was observed in Crohn's disease as compared with ulcerative colitis. Regarding age, highest risk ratio were observed in young patients. And among patients without cardiovascular risk factor identified, the risk was maintained in Crohn's disease, whereas no increased risk was reported in ulcerative colitis. The risk increased progressively with an increasing number of cardiovascular risk factors as expected. In the analysis assessing the impact of disease activity as expected, male sex and cardiovascular risk factors were associated with the increased risk of acute arterial events, but also disease activity with a hazard ratio of 1.74 in Crohn's disease and 1.87 in ulcerative colitis. In summary, in this nationwide population-based cohort study including more than 200,000 IBD patients, we reported an increased risk of acute arterial events in patients with IBD compared to the general population, with the highest risk ratio in young patients with Crohn's disease, and we also established a clear link between IBD disease activity and the risk of acute arterial events. Our findings are in accordance with the hypothesis that a tight control of inflammation could avoid IBD-related systemic complications. For arterial disease and IBD, the impact of treatment, including anti-TNF, still has to be addressed. Thank you.